Hi everyone, my name's Bri and I'm the Cognition Clinical Lead at Monash Health, and I just wanted to provide a little bit of an update around what I'm doing in the delirium space, and I just wanted to acknowledge Dr. Julie Lustig, who I work very closely with. So Monash Health is in Australia, we're in Melbourne, and we're the largest public health service. We have 5 main inpatient campuses and then a whole host of community services in the southeastern area of Victoria. Our delirium initiative really focuses on comprehensive care and includes educating and upskilling both clinical and non-clinical staff. We're really looking at education, screening, management, what's our current resources, how does our environment look, and we want to make it sustainable. We want this to become part of everyday practice, and obviously we're keeping the patients and their families at the forefront of this the whole time, and they've been involved in the consultation process from the get-go. So we're quite lucky. We have a new lot of national standards now, so they've gone on to the 2nd edition, and as part of this, we're required to demonstrate what we're doing to screen, prevent, and manage patients who come in with cognitive impairment, and in particular delirium. So now we have this framework behind us that we actually have to demonstrate that we're achieving. So it gives us a bit of motivation and encouragement to actually look at what we can do in this space. So we have used the CHOPS framework, which is the care of the confused hospitalised older patient, and that really looks at the focus areas of cognitive screening, risk identification, assessment of the older person and management of the older person, and then obviously throughout that we're looking at communication, staff education, and that supportive care environment. We have developed a really comprehensive delirium and dementia in hospital guideline that outlines roles and responsibilities, the resources we have available, the timing of when we want the screening done, and kind of the workflows around that. So if someone has scored positively or we're concerned they have delirium, it steps through what we should be doing. We now have electronic medical records. So previously we were paper-based, and now the 4AT, which is the screening tool that we're using at Monash Health, is built in there, and it kind of helps staff with the workflow, because once they've completed it, it triggers a whole host of actions. There's a medical assessment component, and they can use a delirium order set to help with clinical investigations to try and look at those underlying causes. And obviously non-pharmacological management is where we spend a lot of time planning out what options are available to really individualise that care to that person in front of us. And we use 2 communication tools called the Sunflower and Top 5, which I will show you. And then there is an element of pharmacological management, and that's outlined in our acute behavioural disturbance. So we're really clear that this is only to be used in certain situations, and having patient and family information both written and being able to have that discussion with them at the bedside is kind of what we're trying to implement throughout our network. So Ward H is a geriatric evaluation management unit of 30 beds out at our Casey campus, and they were our pilot ward. We really wanted to, make sure that what we had in place was appropriate and that we're on the right track to, creating a sustainable change and improving our patient outcomes, reducing harm, and improving patient experience and staff knowledge and experience too. This was World Delirium Awareness Day in 2019, and that was kind of our launch of like, hey guys, what can we do in this space? I just want to acknowledge the team there too. It was really around starting small and scaling up. We had partnered with Safe Care Victoria and the Institute of Healthcare Improvement, looking at a Delirium Collaborative around, sharing ideas, what can we do in this space, and really using that quality improvement science methodology to drive and listening to the data and kind of create that sustainable change. We involved key stakeholders from the start, keeping patients and families involved. They were there writing down ideas, the bedside clinicians, managers, and all the way up to executives. So everyone was involved and everyone knew the process, and this was our process map. It was, such a good activity to do. We started around what our current care was like, and then what we wanted to achieve, and potentially how we could get there. We set up an ideas board on the ward that everyone could add to and kind of see what we're doing in this space. It had our progress and data there, and then kind of the next steps. it was okay to fail. I think this was a really big lesson that we learned. This was my brain cake in 2019 that I had never made before for World Delirium Awareness Day. And then I realised that using white chocolate and the thickness probably wasn't the best idea, and I hadn't tried it before, and I just expected it to work. So I did learn from that, and I then made more of a cheesecake mould for last year, which turned out a lot better. So I don't have a picture of that one up there. So I think the whole purpose of this is that to let staff know that if it doesn't work, we'll look at another alternative. We're not going to try and say, as of tomorrow, we're screening every single person and it has to be done within, 8 hours. It was like, well, let's build on this. How can we build it into everyday practice? And it just becomes part of standard routine. So, do we look at exploring the doctors to do it? Do we make it on admission? Do we make it kind of in after hours that everyone's screened on that kind of 7 p.m. ward round? So it was an opportunity to explore and look at innovative ways that we could, screen for delirium and cognitive impairment at Monash Health. So these are our 2 communication tools. So this is the Sunflower and the Top 5, and they're really just, information about me and getting to know you tools. So we could fill it out on all patients and technically all staff, as it's just, it doesn't say, oh, this person has a cognitive impairment. It's actually just getting to know Elizabeth, who likes to be called Betty, as a person rather than, bed number 5, for example. So the ward decided to complete it on all patients that came in because they felt that that was really important in providing that person-centered care to everyone who was there, not just patients who came in who had a cognitive impairment or delirium. And then the Top 5 is really where we started to engage with our patient and family. And, is there any routines or preferences that this person has that we can try and incorporate into their hospital stay? So knowing that Betty gets up really early kind of helped plan the day, and we knew that Betty would be an early riser and we could get her set up and started for the day. Having a cup of Milo, which is hot chocolate, at 8 p.m. before getting ready to bed really helped with her sleep-wake cycle and her usual routine, especially when that's kind of thrown out of whack when you're in hospital. So this is our new education module. So there's just some screenshots up there of our online learning package, and it's really tailored to each, discipline area. So people know what their roles and responsibility are. We've tried to put it into a 15-minute package, which has been quite challenging, but it really just gives you, it's another element, or gives you one snapshot of what we should be doing in this space. We've also developed some for our non-clinical staff, so around our food and environment staff, our ward clerks, our security, and our patient observers as well, because we think it's a whole team effort to be able to make a difference to the care of our patients. On Ward H, they've got a delirium pod, so they came up with, they've got a little space on the ward, which is now labelled delirium pod, and it has all the resources there they need. So there's a little environment checklist, there's the patient and family written information, there's spare sunflowers, there's diversional activities there. They can kind of go through and see what's going to work for that patient if needed. So it's kind of that constant visual reminder. It also, patients and family can see it on the ward, so it opens up that conversation. What's that? What's this? Can we access it too? So it's just a really good open communication policy on Ward H. And this is one of their delirium boards, so what to know about delirium. They've filled out a sunflower for Ward H, so their interests are delirium and the people that are important to them are patients and families. And it's just been, a bit of a change in that culture and vibe, and people are really starting to think, hey, what can we do in this space? So it's quite exciting to be part of. So this is some of our data. So it has changed more recently. We were originally looking at 24 hours, but we've now updated our policy to be screening for cognitive impairment within 8 hours of admission, because we know the sooner we can identify and recognise it, or the sooner we can prevent it, the better outcomes for the patient. So I can confidently say that we are still within the 90% range of completing the 4AT within 8 hours of admission. But when we commenced this work, we were starting at a baseline of 0. And then you can see we slowly started to trial and test a few changes and kind of slowly build up until it just became part of consistent practice. So that has been maintained. This kind of data collection went on till April 2020. So I apologise, not all of the data's there, but I went back and checked and we are kind of still sitting around that 90% mark. So I think that just highlights that this process is now part of everyday practice. They don't need me or some of the other delirium champions there kind of driving it on the daily. And our falls, so we had quite a high falls rate, so this is the raw number of falls in our ward. And over time, we thought if we could tailor that individualised care, looking at the environment, setting up their routines and preferences and some of the strategies that work for them in their, their usual life and usual care, how can we try and do that here? And you can see our fall rate did go down, and it's continued to stay quite low, and we've obviously still had falls, but unfortunately I don't think we can completely prevent them, but we haven't had any falls with serious harm. So I think that's really important to note. Our average length of stay, so this is a geriatric evaluation unit, so the average length of stay is a little bit longer than your acute setting, but we obviously can't solely attribute the Delirium and Dementia Initiative and framework to this, but I definitely think it's contributed to reducing that length of stay because we're providing that individualised, tailored care. We're getting to know the person kind of before they even hit the ward. So, tailoring that with all the other strategies that are going on across the organisation, we've been able to reduce our length of stay, and I think the average is still sitting around that 22-day mark. There is still room for improvement, as always, and the use of antipsychotics is a big one, and benzodiazepines. And with the national standards and accreditation that I spoke about earlier, we now have to demonstrate what we're doing to reduce our use of antipsychotics. And you can see here we were trending down, and it peaked back up there for a little bit. And, we discovered that that's because I was on leave. Some of the other delirium champions were on leave at the same time, as well as our junior medical workforce rotated. So I think that just highlights that it wasn't built into our processes yet. It was still very person dependent, but with the introduction of electronic medical records, that's changed quite a lot because there's a lot more algorithms and care strategies there, and it's very explicit that if you are using pharmacological management, we need to be using those non-pharmacological strategies too. And staff knowledge and patient experience, and I think that's what it's all about. So throughout this process, you could just see the vibe changed on the ward, and people felt like they could do something for our patients with a cognitive impairment, and they had options and resources, and they knew how to have a conversation with the family, and the nursing staff knew how to express their concerns to the medical team. The medical team were asking about a person's cognition, and the word delirium was getting used, which, that word has never really been spoken about before. So some of the quotes you can see, I sung Elvis to my patient in the corridor last week as it was identified on the sunflower tool, and that got my patient to walk. And obviously we know how important mobility is as an intervention, and this patient, he just, wasn't engaged, didn't want to get up and participate in therapy and care, and they played Elvis on the phone with the nurse, the physio, and the occupational therapist, and it just lit up his face, and he got up and kind of moved around and started to dance so they could kind of do a little bit of a mobility screen while he was there. And, the patient loved it, but the staff also felt like they had something to offer, and, and that's kind of what we've been trying to promote throughout this implementation process. That increased communication that I spoke about between the multidisciplinary team and kind of having those open conversations, and, the family as well. So you could tell that they were listening to my concerns and what mum likes, and treating her like Mary, not patient in bedside. And they even took their sunflower phones, so when carers visit, they've got that, easy how-to and quick engagement of interests that Mary has. So that's kind of, that's just a quick snapshot of what we've done in this space, and I'm really looking forward to seeing and hearing what other people are doing across the globe. So thank you, and if you have any questions, reach out.